Well, good afternoon, everybody. We want to welcome you to the Solutions Group webinar here today called Potential Compensation Pathways Around the New Healthcare Provisions for the ARP. This afternoon, we are joined by Asbel Montes and Brian Werfel. And so we certainly want to say thank you to everyone. Thank you to Asbel and Brian both for making the time and doing this with us all today. It's exciting. Just a couple of quick housekeeping issues. One, as you guys probably heard, a global DNS disruption happened yesterday afternoon. I think there's a couple 100,000 websites across the world that are having delays and issues and things like that. So if you start having audio trouble, if you would, just simply refresh your browser. If that doesn't fix, at that point, you may close out of the browser and reopen again. And if that doesn't work for you, my team is standing by. You can email marketing@solutionsgroup.com, and I'll be happy to try to help you best we can. At the end of today's session, we are recording. We'll be sure and push out a replay link as well as a copy of the slides for everybody. So you'll receive those more than likely by end of day today. And so that stuff will be coming out to you. And so with that being said, we're excited. So today we've got 250 unique providers with us today from across the country, about 310 total people. So we appreciate you guys joining us this afternoon and look forward to sharing some information with you. If you're not familiar with Solutions Group, my name is Brian Choate. I'm the founder and managing partner for our technology side. Really, we're focused on helping the EMS industry with our passion project. And that is about finding reimbursement for you guys, finding payers, managing claims with high deductible plans. So if you need some information or would like to learn more about our products and services, we'd be happy to have a conversation with you and kind of introduce you to what we do. And recently here, as a lot of you guys know, we actually started a new division for Solutions Group. We're very excited about a consulting arm headed up by managing partner Asbel Montes. And so it's the most fun and the most work we've had in years. So a lot of fun. So with that being said, again, we thank you guys for joining us. If you would, I'm going to turn this over to Asbel and Brian, let him kind of greet you guys. And we look forward to taking it from here. Thanks for joining us.
Perfect. Thanks, Brian Choate. And Brian Werfel, thanks for joining today. It's always fun.
To be here.
And I can promise you guys, we were going to have some banter before this call. We were already having let's keep this going. This is the fun part of the presentation, but there's a lot to cover, but we're going to get and do a deep dive into some very specific provisions that could be advantageous for the EMS industry. EMS agencies. It does require some work though. As well. But we do want to make sure that you understand it, what's out there, the billions of dollars, no matter how you feel about the American Rescue Plan Act of 2021. We are going to go through the provisions of this that could be helpful. The bill has passed, so wherever you land on it is where it is. But we do want to make sure that we're giving you a disclaimer here, even though Brian Werfel is an attorney as well. None of this constitutes legal advice. Attorney-client privilege or what have you. Some of the stuff that we're going to be giving you is for illustrative purposes only, but we just want to make sure that you've got information as well. And we always strongly suggest that you seek your accountant advice, your own legal advice or what have you. And then of course, if you want legal advice, you can always call Brian Werfel as well. So let's see if I can make this move correctly through the process. So everybody knows, unless you've been sleeping under a rock or something, that ARPA 2021 is what I'm calling it, so we don't have to continue to call the American Rescue Plan Act of 2021, was passed, second largest package in the history of America, the first being just about a year ago with the CARES Act. Both were around the same amount of money. One was a $2 trillion package. This one was a $1.9 trillion package as well. And there's three key provisions within the act. COVID-19 relief, and I'll go just briefly over that. There's some individual aid, business aid. If you attended the American Ambulance Association's 50,000 foot view, as we talked about ARPA Act of 2021, Brian Werfel, Scott Moore, myself, we did just a really good job of trying to give you a very high level overview. So I'm not going through some of those provisions, but just to kind of touch on some key elements for you. And I'm kind of going through this. There is a chat window. So as you have questions, put yourself in the chat, ask the questions. Brian and I are going to take these back and forth. as well. We did leave one thing that I know most of you guys are probably on here for, is we do a very deep dive into this, is probably where we're leaving that to the end of the presentation. So it's not overwhelming and takes up the whole time, and we cannot get to some of the other provisions as well that we wanted to make you aware of. But there is $415 billion in ARPA that goes for vaccination programs, COVID-19 testing, and related activities. Now, you're going to see some web links push out here that we want to bring your attention to. The first one is, if you're not aware of this, on March the 15th, the Biden administration increased the vaccine administration fee from approximately, it was around 40 bucks for a 2-dose. It is now $80. So you get 40 bucks a dose. Now you're seeing this come here. If you click on that, it will take you directly to the site. But starting March 15th, dates of service, if you are doing vaccinations, your administration fee pretty much has doubled for the Medicare fee-for-service population. It's hoping, of course, with commercial agencies, Medicaid, some of you guys are getting more than that based upon what state you live in. Some carriers are paying more than that, but at a minimum, the Medicare fee schedule has almost doubled, which also means for those where the administration fee is either not covered by the insurance carrier or it's an uninsured patient, that means if you're submitting it through the HRSA uninsured portal, that fee rate has also increased to $40 each administration. So if you're not aware of that, and maybe you've been playing around that you haven't been doing vaccinations and you stopped because the juice wasn't worth the squeeze, well, the juice might now be worth the squeeze in your area as well. Right, Brian? And Brian's laughing at me over here. But I do want to make sure that get that new, because that is a new piece of information and it's slowly filtering through the industry as well, and decided to kind of just talk about that. Anything to add there, Brian?
Yeah, no, other than just to say that, you know, part of the $415 billion will go to fund that new increase there. So.
Yeah. So that's why you're seeing that. A lot of people are like, well, how did that happen and why wasn't it retro? A lot of that is dealing with the passage of this bill as well, and what have you. Now, the other thing that I want to push out is, and this was just released as of last night with the Biden administration, and you're going to see this also push out to you regarding the next HHS release, is about $10 billion was appropriated to additional COVID testing to really get the schools going. Now, a lot of you guys are doing COVID testing. You've been asked by your local governments. You're doing a lot of stuff at off-site testing issues as well. If now that there's another $10 billion being appropriated, actually in the release, it tells you by state that this is happening as well. And so if you take a look at different states, you can see, for instance, most like in Louisiana, it's 160 million. In Texas, it's almost $1 billion. That is being distributed by the states to do this COVID testing. So you might want to refocus where you're doing COVID testing and may think, I need to start partnerships with schools in my area as well. So these are different ideas, guys, that we're wanting to talk about. As things keep pressing and pushing out, start thinking outside the box. A lot of you are thinking about workforce shortage issues that you might be having, but remember, there's a lot of funding's being pushed out. Testing's important. The next concentration appears to be around the schools right now. And there is $415 billion appropriated. That is a lot of money, Brian. And so right now they pushed out $10 billion. They've raised the rates for vaccination administration. So just expect to see billions more dollars start flowing through vaccination and COVID testing. So stay in tune with what the Biden administration's releasing. And I would just assume that it's going to be in lots of different tests as well.
Yeah, and I think the only thing I would add in terms of the broader testing regime is what a lot of states are finding is, you know, this is really an exercise in logistics. You know, you have your labs that perform the actual tests themselves, and then you have the end user, the school or whoever that needs people tested, and the labs are used to the samples being delivered to them, right? And the schools are not in the business of shipping patients off to, you know, or students off to labs. So where we fit in, I think, is actually solving that logistical challenge. So either, you know, doing the swabs and then moving them to the labs or vice versa, or especially up here in New York, what we're seeing is a lot of these mobile testing labs popping up in trailers and, you know, construction trailers and that sort of thing. And EMS has played a big part of that. So Asbel's right. There is going to be a ton of money here. There is a logistical challenge that's associated with it, but you are in the business of logistics, whether we realize it or not. So there is a role for you to play in bringing labs and schools together. So don't be shy about this one. This is a ton of money.
Yeah, think outside the box. Get creative. Get creative with your local, state governments.
Put it in perspective, $10 billion, which is just the initial rollout of this testing piece, is twice what we spend on Medicare ambulance every year. Right.
That is
and
a
that
good
will go
point.
in a month. Right?
That's a good point. And think about it too, guys. There's 360 billion that's going to local and state governments as well. So there's that additional money that's even going, and this is not going through the states now. It's going directly to local governments. And so there is a list, and I'm not sure I have it here. We can probably send that out later, and I may not have given that. But I'll make sure I get that up. But there's actually a spreadsheet that tells you by each different city how much money they're getting appropriated as well. That goes directly from U.S. Treasury into the city or into the county, whereas there was a threshold of how many individuals lived in there. I think it was 500,000 or more got a direct appropriation in the CARES Act. This time there is not that limitation. It goes directly from U.S. Treasury to the city or the county. So relationships might be a little different. You might have more of a relationship with that local area to help you augment some of the things that are related to that. There is some specification, and U.S. Treasury, of course, is going to have directions to local and state governments of how they can use those funds as well. But you are in public safety, so there could be some avenues available to you to either subcontract, if you're a subcontractor to a contractor, or you might be a nonprofit, private nonprofit EMS system, or a governmental EMS system, because there's a lot of you on here as well that would have direct appropriation. If you're private, it's going to be a little different nuance to get through that funding piece of it. It's doable, but it will be a different nuance to get through as well. Won't spend a lot of time on that, but just wanted to make you aware of it as we go through the process. Individual aid, I'm going to spend 30 seconds on that, folks. That's a part of it as well. This is where you're hearing about all these other $1,400 checks that you're getting. That is controversial. From some people support it, some don't support it. I'm not here to opine on that, but there's a lot of individual aid around mental health, around COBRA assistance, the Affordable Care Act. There's some provisions that were put into there. There's emergency rental home housing assistance, child care. And the only reason why I'm bringing this up as well is because a lot of EMS agencies employ individuals too that might be in certain thresholds. This could be advantageous to your individual employees. So understanding what's available to them is another way that you can interact and engage with your employees to make sure they understand where the resources are. And hence the reason why I'm bringing that up, because it does parlay in a little bit with your business design and assistance with your employee base. It also has a lot of business aid. I'm going to strongly suggest you, and I think there's a recording of this with we actually went through Brian Werfel. Scott Moore did a phenomenal job going through the Paycheck Protection Program, the EIDL. There's also an FAQ that the American Ambulance Association has that will be going out to those as well. So I'm not going to opine too much on that or what have you, but there is a lot of money here. A lot of money for agriculture, doesn't really impact EMS. But if you're wanting to know what pieces of the package are in there, a lot of stuff is flying out there. Here's a good piece if you just want to kind of see where generally some of the money is going through the process.
Yeah, the only thing I would jump in there and just say is if you were looking at the PPP program and your second draws, keep in mind you've got a March 31st deadline. So, that's one that you do need to work fairly quickly. So if you haven't already applied for your second draw loan and you believe you're eligible, there are different eligibility criteria than the first time around. You do need to document an actual loss of revenue for those second draws. But if you believe you qualify, contact your bank sooner rather than later, right?
And the only thing I would do here too is if you got specific questions around PPP and want some assistance with that as well, send us your email or whatever. We'll connect you with Brian too and make sure that you got some of the resources that came through the American AMP that was done extensively on that. So I want to get to some targeted healthcare provisions, especially around the compensation realm of some of the sections that are within the ARPA. Kind of need to look and where you need to go. And then we will follow up with a deep dive into the treatment in lieu of transport provision or what most people are calling the treatment in place provision. And we'll do a little deeper dive and spend some time around that as well, because I know that's probably what a lot of you want to understand. So Section 2705 of the bill is grants for healthcare providers to promote mental health. You're going to see a lot of mental health provisions within ARPA. We all know that was unfortunately, because of COVID-19, this is an unintended consequence. Substance abuse is on the rise, mental health is on the rise. And so there is a lot of provisions looking at that, especially in rural and underserved communities. If you typed in rural and underserved in the 600-page bill, you're going to see a lot of reference to rural America and underserved populations, right, Brian?
Yeah, I mean, pretty much, this is what in Washington is called a Christmas tree bill. Everyone adds a little bit to it, right? Basically, the nexus to get your ornament hung on this tree was to basically connect it in some way, shape, or form to a rural or an underserved community. So a lot of the provisions we're going to talk about here are available, but limited to, one of those two, communities. So
correct. So if you are a rural provider listening today, or you are predominantly working in underserved communities, you're going to see a link push out that I'm suggesting you make sure that you sign up to the HRSA listserv, because HRSA is going to oversight this grant process. And there's a few of these things that we're going to discuss here today. In this provision to promote mental health wellness amongst EMS, amongst healthcare professionals, so EMS is included in that, there are going to be grants that are going to be given through HRSA to address this issue. Now, it's going to be awarded either a grant or a contract to a healthcare entity, to a healthcare provider association. So think about that. Your EMS association in your state could actually apply to help with these type of programs for EMS professionals. If you're not aware of this, and there are a lot of associations that take advantage of HRSA. For instance, I know like in Louisiana, the association, we get lots of grants through HRSA for rural provider outreach as well. So these grants are common. If you're not aware of this, or maybe you don't have, this is something that you should really think through the process that really can help rural providers, and it really is meant to establish and enhance. Now, the scope of the contracts will be done through HRSA. HRSA is used to doing this. So if you sign up for the listserv, we'll also push things out as we become aware that it's out there, because you'll have to make applications. It's going to be like a grant process, but they're going to distribute this $40 million through the healthcare professional workforce. So it's not just going to come to you, and they're not going to just show up and you're going to look in your bank and see a U.S. Treasury amount of money that says, oh, you have $100,000 to promote mental health among the work. No, it's not going to work like that. So you're going to have to go out and get it. If you're an association, there's ways to work through the process, but I wanted to bring that to your attention. Make sure you're signed up on that website for that listserv. We'll get it out there. But once they start doing that, it's going to be, and I would really suggest the industry coalesce around an association. The national associations can do this as well. State associations can do this as well to help and promote this, especially amongst the rural and underserved communities. Section 9811 is really, this basically, guys, is a requisite because it wasn't mandatory coverage from the Medicaid side of things. So technically, and this was really an issue more, I would say, in states that were more probably of a Republican nature, not making it mandatory coverage for the COVID vaccines and administration. So now it's mandatory. Basically, they're telling states that we will cover this at 100% of your FMAP, which that means is typically if they had not addressed the FMAP issue, depending upon what your FMAP was for your state, the state would have to put some money up to cover that administration fee. They have now taken all that out. They made it a mandatory. The states pay nothing to cover this. It prohibits cost sharing, and it actually covers, this coverage expires 1 year after the PHE expires. And right now, the PHE is expected to expire at the end of this year. So this would actually cover through the end of next year. And basically, it's going to be governed by the Secretary of HHS. So if you're in a state that is not covering the administration fee, as we talked about for COVID vaccines, or what have you, they now are, or they now should be. Changing that is now mandatory covered provision, and it is fully funded by the government as well. So just pay close attention to your state. If you're in one of those states where that's not happening and you're doing vaccine administrations, this is an avenue. You should see stuff come out from them amending their waivers or state plan amendments or their 1915 1135 waivers as well. So just wanted to bring that to your attention if you're in one of those states. The next thing that I want to talk about, and this is key, and if you're in, actually it impacts everything, but it's under section 9814, and it is giving a temporary increase in what we call FMAP for expanding benefits for mandatory individuals that are uninsured. So technically taking them up to 100% of the federal poverty level or 138%. So think of this, guys, as extending coverage or incentivizing states that have not expanded coverage under the Affordable Care Act, or what some refer to as Obamacare. There are currently 12 states that have not expanded Medicaid. This is to incentivize those states, saying, hey, if you do this, we're going to give you more federal dollars in your Medicaid program, and you may be suffering in Medicaid shortfalls. This is how to increase that by adding more lives into the system for that. So this is where they're trying to incentivize states. So pay attention, especially if you're in one of those 12 states. But there is a thing that I'm going to push out that kind of gives you a uninsured. So there's two different pieces to kind of show you the uninsured landscape in the nation that was put out. So I'm sending you ASPE's uninsured estimates by state, which is kind of a nonpartisan group that looks at the uninsured lives across the nation. So you can kind of see what those are, because every one of us are in those states. Some are in states that have higher uninsured populations than others. This is to incentivize them through this public health emergency to try to insure more of these lives. You're also going to see an HHS fact sheet that just came out regarding this, where it is by each state, and if certain states did this initiative, how many more uninsured patients would go into the pool. Now, I'm not getting into this about how much money this bill is costing and our taxpayers are all paying for it. It is what it is, folks. It's like Obamacare. The money's already been out there and appropriated wherever you stood on it or whatever. Our industry has a shortfall. We have a high uninsured. How do we make this up? And this is a state initiative, but you need to understand that this is happening in your state. So when you're talking to your mayors, you're talking to your representatives, you're talking to your governor's office, you're talking to your administration, here's an avenue that I want to make you aware of, that it's an issue within your state. Here's where it's at. And sometimes we have to take off of our political lenses and put on our more practical lenses as we work through this process too, or what have you. But there is a provision in here that allows for it. This is 5% is basically an incentivization to the states to do it, to get more federal dollars. That brings more dollars down to cover lives. Brian, anything to add on there?
Yeah, I mean, this is probably the Medicaid expansion is at this point the single largest political hot button topic in the Affordable Care Act. I mean, this is the provision that was litigated at the Supreme Court, where the defenders of the Affordable Care Act were forced to argue that it was, in fact, not a tax, but a tax at the same time. This is where Justice Roberts declared it a tax. This is what prompted the Republicans to then zero out the actual penalty, right? Among other fights that we're having. But what we're seeing right now is when it was initially done, the expansion, the federal government bore 100% of the costs of the expansion. And as a result, many states did, in fact, do it, whether because they were ideologically attuned to what they were trying to accomplish or because they just saw it as free money, right? We're now 10 years out from the adoption, where states are now forced to bear a portion of that burden, 10% in fact. So the federal government pays 90% of the cost of the expansion, and the states are bearing the cost at 10%. So now you have these states that haven't expanded, and now they're seeing, well, if I wasn't willing to do it when the federal government was picking up the full freight, I'm certainly not going to do it now when I'm on the hook for a portion of this. This is attempted to basically cut in half their financial burden if they wanted to basically rethink the expansion. Several of those states that didn't expand have had changes in administrations since then, or changes in legislatures where they believe that they might be more ideologically inclined to now jump in. So this is definitely dangled as a carrot for those states to jump in. For you, what it means is that those uninsured populations would then have insurance, right? So there's really nothing for us to do other than to just be mindful of what the state might do. But certainly it's something, if you're in one of those 12 states, that you're going to want to keep an eye on. Right.
Keep an eye on that. And also this could be political pressure that you could put on from your agency in those unique states to kind of work through. But I would anticipate eventually, with it standing up to what Brian's point is, most people, you're going to start figuring out a way how to creatively say that, where they're going to expand coverage without calling it expanding coverage. So you do see unique things that people are trying to do.
Republican administrations that ideologically don't like it are starting to come around to the realization that they're basically just subsidizing everyone else. Yeah. So they might as well dip their straw into that, trough at this point. So
exactly. So moving on, Section 2703 is a funding for mental health and substance use disorder training for healthcare professionals. Again, this is another $80 million that is going through HRSA to do something similar to developing and operating to help health professions and nursing for healthcare students, residents, professionals, of which we are one, to reduce suicide, burnout, mental health conditions within. So think more of like your CISD programs that you might have, or some of you may not have that. This is what this is going to be doing. And it can be done through something very similar. HRSA associations is what I'm really strongly suggesting. If you've got an active association, get active. This could be the conduit to help that piece
or universities in this case that operate those EMS training programs. So
the training institutions, if you're partnered with someone. So just think things through the box. There's a way to get this money, but you might have to partner with someone else to make sure it flows in to EMS because it's not as obvious in this one, but it will happen for you. You just got to figure out who your partners are that you're working through. And this is somewhere I strongly suggest either an association, or if you're an EMS academy that you have, a lot of you guys are that you plug and play, and make sure you're on that HRSA listserv, because that's where all that information is going to come through. But there's $80 million appropriated to address this issue. And this is an issue in our industry. Not just nurses and doctors, but our EMTs and paramedics. This has been a pandemic that's been ongoing for a long time. And we're seeing that. We're seeing suicide start happening. We're seeing burnout. People are leaving the industry altogether. And this is something that thankfully they're addressing and trying to put some money in there to do that. The other thing is that I did want to bring this up and spend just a little bit time on this, because many of you guys are starting to do this. Maybe you've been doing that. You've been working, trying to figure out with your states, how do we get more money? And so I want to talk about the community-based mobile crisis intervention services, as they are calling it, in Section 1947. This is the first time you're hearing about it, and you are doing mobile health, community paramedicine, whatever you want to call it. Here is an avenue for the crisis intervention under the substance abuse and mental health piece. So what we would call the crisis care. They are appropriating funding through this, through the state plan amendment, and it's incentivized, and it is supplementing what states are doing, not to supplant what they're already doing if they're already doing something, but it's giving them more federal dollars. And so here's how they define it. Outside of a hospital or healthcare setting, that's us. If you're doing it, if you're not doing it, here's now the opportunity. They're experiencing a mental health or substance abuse disorder. This happens in our industry. And it is turned by a multidisciplinary mobile crisis team. So that means it has to have a behavioral health care professional, just one, but it can have a paramedic with it. It could have an EMT, it could have a social worker, it could have whatever this crisis team has, and they have to respond in a timely manner. They have to be trained in trauma, de-escalation strategies, harm reduction.
That's what leg up on this one over any other provider, right? I mean, there are other mental health responders out there, but they are not inclined or frankly logistically capable of, quote, responding in a timely manner.
In a timely manner. And that is why it's really
do not have the bandwidth to get out immediately, right?
You are exactly correct, Brian. And that is why I'm suggesting that if you've not been looking at this, or you've been thinking, hey, we've been wanting to do this, but there's no funding, or we're trying to work through the funding, or how do the states get the funding? And some of them have been talking about it, but slow moving. This is the piece that's going to incentivize states to start working through putting together either a state plan or what have you. This provides for screening and assessment, stabilization, coordinating. This is stuff that we do, or we've been doing, or you may have been piloting already in your standpoint. Maintaining relationships with your community partners, your managed care organization. Some of you may not be as involved with that, but that's an area where you are synergizing with the mental health community, the substance abuse community as well, that may have some of these relationships going. Here is where they incentivize the states. They are changing the FMAP to 85%. So if you are a 60% FMAP state or a 65% FMAP state, this is a significant increase for this population of federal dollars coming to you to be able to administer this. Now, there are some stipulations regarding this for the states. If a state already has a program, they can't just scrap that program and say, oh, I'm going to do this new program because now I get more whatever. No, it supplants what they're currently doing. So it's going to enhance it. It's going to increase more money into them as well. If there is a state that's not doing this, then of course they would kind of work through that process and nuance that as well. They've also appropriated money to HHS. This is why they're serious about it. They've even given money to HHS to say, we're giving you $15 million to put together a team to work with these states to get these implemented by their 1115 or 1915 waivers. What that means is
sort of a new thing, right, Asbel? I mean, to my knowledge, I'm hard pressed to think about another instance or another issue where HHS has not only said basically, I invite or encourage you, the states, to develop your own waivers and submit them to us, but actually appropriated money to basically encourage states to submit these, right? They want to spend this money, right?
You're exactly correct. So they're wanting to do it. They understand it's critical. They're understanding we need to have a team at HHS that's going to help the states. So we're not only increasing the FMAP, we're going to have a team at HHS that's going to help them move through these 1115 or 1915 waivers as the states submit them to do this. So if you've been talking to your states, because I know a lot of you have reached out and many states have been talking to them, trying to work through this process. Funding was always an issue for some of the states on how they could fund it. Well, now they're removing some of these barriers. And so you might want to re-engage with your state again, because really in every section outside of the treat and transport that we're going to go to next, this piece is extremely advantageous to the EMS industry to get involved in. And it's permanent.
Unlike many of them, it's permanent.
And it's permanent. That's a good point, Brian. And it's permanent, folks. So if you've got questions about this, guys, feel free to call up. If you're not sure how to do that, there is a question and there's a way to contact us at the end of the slide. I'm suggesting you reach out. There's a lot of us that have some great ideas on how you can help maneuver through that and do that. But I'm strongly suggesting you take a look at this and work with your states in those areas if you're not already doing that.
Yeah, and the other thing I would add is it is also a stepping stone to treatment in place on the Medicaid side, right? Essentially, that's what we're talking about. Now, it's limited to that behavioral health population, but once the state's gone down the road of paying for that, you can start to see how easily you could expand it to other categories, similar to what we're about to talk about.
Absolutely. And so here comes, Brian, the infamous section 9832.
Treatment in lieu of transport, huh?
And you know what? I got to give Brian credit for that, because it's not really a treatment in place. I said, you know what? He said, Asbel, we were on he said, we probably should call this treatment in lieu of transport. I said, we are going to use that. And so I'm calling it the treatment in lieu of transport section, thanks to my esteemed colleague here, Brian Werfel, and his nomenclature there, because that's really what it is, guys. It's not treatment in place as we probably see it, not the way that the section here. So I'm going to let Brian kind of explain exactly what the statute says. And then him and I are probably going to banter back and forth on this and make it quite lively for you as well. And then as you have questions, please use that chat because some of you might have, but I'm going to do a deep dive, give you guys some thoughts around that as we kind of dive deep on how you would implement this once it was done as well, too. But let's just kind of talk about what this section actually says, Brian.
All right. So in order to set the stage, what you have to keep in mind is that the Medicare ambulance benefit itself is, with one very narrow exception related to those individuals that die at the scene before you transport them, it's a transportation benefit. So while for the past several years, advocates for the industry have been in discussions with CMS about the notion of paying EMS providers not to transport in lieu of the transport, right? And CMS is not ideologically opposed to that. You've seen a manifestation of that model in the ET3 program, which they're demoing, right? And they have the authority to test new reimbursement models under the CMMI project. But what they don't have is the authority to rewrite the Medicare statutes at large. So in terms of responding to the pandemic, what we saw in the early stages of it was a big concern about hospital capacity and the idea of, whenever possible, keeping patients out of those hospitals. So in part, what you saw is CMS waive its destination requirement so that those patients that could be transported to other places, an urgent care center, a physician's office, et cetera, would do so on the theory that by reimbursing you for that, right, there would be less of an incentive to bring those individuals into the hospital when we were worried about hospital capacity. But CMS couldn't implement what it's calling treatment in place, what we're calling treatment in lieu of the transport. And you'll understand why we're calling that when we get a little deeper into this, because they were arguing that their hands are tied by the language of the Social Security Act. And while it's not the answer we wanted to hear, it's almost undoubtedly correct, right? So what Congress has done here is to say that during a declared public health emergency, CMS has the authority under 1135B of the Social Security Act, that's its general waiver authority, to waive the transportation requirement, right?
It doesn't mean it has to. It just gives them now the authority
Right.
to waive where they said they didn't have the ability.
Right. So now, instead of CMS saying, I wish I could do it, but I don't have the authority to do so, now they do, right? Only during a public health emergency, but they can, if they want, waive the transportation requirement. Now, the reason why we're calling this transport in lieu of a transport instead of treatment in place is it does not apply to all situations where you treat the patient at the scene and then don't transport them. It only applies, A, to 911 calls or their equivalent. So we're talking about your emergent responses to acute medical conditions. So this is not an interfacility expansion. This is not a non-emergency expansion. This is not right. And it's those community-wide EMS protocols that we're really going to talk about. So the way the language works is CMS can waive the transportation requirement and reimburse through the Medicare program, the original Medicare program, not the ET3 model, the original Medicare program, if the reason you don't transport the patient is because of a community-wide protocol that either says you must not transport them or you can choose not to transport them due to the current public health emergency or whatever public health emergency is in effect at that time. So this is a little bit different than ET3, which doesn't get into the motives of why you didn't transport the patient, right? It just says it's a much broader program. It recognizes that it's more expensive to treat them in the ED. We're not going to get into why you didn't take them to the ED. As long as you do, or you don't take them to the ED, excuse me, you'll get your payment under that telehealth fee. Here, we have to ask why you didn't transport them. So
And
it's
I think it's
analysis, right?
Yeah, and I think it's important too, because this is where the confusion has in, and some of us have got a lot of an inside baseball knowledge as we worked through this very grueling piece over the last year.
Right, just to be clear, he means him, not me, but yeah.
And what I mean by that is there's a lot of us that were doing a lot of advocacy. So from the American Ambulance Association, a lot of you guys know I'm heavily involved with the American Ambulance Association, and there was a lot of us advocating to do treatment in place, not just the American Ambulance. There was a lot of associations doing that. I'm just work extremely heavily with the American Ambulance Association. And so there's a lot of inside baseball, because originally we wanted this to be treatment in place, but there was a lot of concern at the very beginning of the public health emergency. The hospitals were backing up in parts of the country, and people were saying, we only want the critical patients, and if they have COVID, everybody else, if you can treat them in place. There were some that were mandated to treat in place, some to give them the options, and it's like, we don't even have an option to take them anywhere. Or hospitals were going on to, we can't take them anywhere. Right. Because of these certain things. And so that was the reason behind it. Then there was concern that there would be abuse because of the ET3 model that was going on, how that was going to conflict with the ET3 model, and how would we manage that if it wasn't in those circumstances that somebody just wasn't going to start treating in place and billing for stuff that was not relative to those conditions. And that is where all this language started to go back and forth. Well, is there such a thing as a community-wide EMS? How do we know that that was mandated? Is there something in written order? And then when CBO came back with—
right there, Asbel, right? Community-wide, right? Just so everyone, I think, understands what we're talking about here. I think that language, correct me if I'm wrong, exists to distinguish between a protocol that your company has, but another company in the same geographic area might have a different protocol on, right? In other words, what they wanted to get at is a situation where the reason you're not putting this individual in your ambulance and transporting them is not because you're choosing not to do it, or because your hospital asked you not to do it. But it doesn't matter whether it was your company or some other company, neither of you would have the choice under that, right?
Right, under that community-wide. And that is a very relevant piece to know. And then when we found out what the score was that came back, it was just a nominal score. It was around $10 million a year. So it wasn't a lot when it came back. And so that's where they're thinking it could be very restrictive or what have you. So when we talk through this process, and I know a lot are saying, well, we can do this here, we can do that here, we can. Under the waiver authority, it's pretty broad. But we do understand when CMS came back with their technical assistance on the language in the bill, that there was a very narrow concept of what they were thinking through the process. And if we as an industry do not get this right out of the gate, or CMS understands, oh, there's going to be people trying to exploit around this, they will not implement the waiver. And that is the concern, because we're not out of the woods yet. So this is where we get to, what are the next steps? Step one is CMS has to issue an 1135 waiver. And the hope is that we're trying to do is that they will make this retro back to March 1st, like they've done with every other waiver that they've been doing. And that's what we're looking for. So we're looking for it to be retroactive. So in some spots of the country, as it started to come into the country, namely through New York City, it was coming in through LA, that those provisions started very quickly, where they were actually not take them to the hospitals and things like that. And then it just kept blanketing across the country. And it might have been a written protocol. It might have been something else. There's ways that I think we can nuance this and have discussions with CMS as we work through waiver authority. But that is step number one. That work is ongoing. There is work kind of working through that process to make that happen. There is no guarantee, though, it's going to be retroactive. They could come and issue a waiver and say, it starts effective today moving forward. So I just want everybody to be clear
and in fact,
that is step number one.
From their perspective, that a lot of the questions that I assume we're about to get hit with, and I realize I should have used that language, that we're going to get from people, certainly please ask them.
Yeah, please
but a lot of the questions that we've gotten on previous calls about this are basically based on the mechanics of going backwards and amending protocols and that. So I could easily see CMS's view is that it's just complicated. This is a trial run for the next public health emergency. Let's just do it going forward, right?
So just to keep that in context, we're all just opining what we think will happen. I will tell you there's advocacy work going on to make it retro, but I will tell you there's probably going to be as they keep coming to make sure, how do they make sure it's not being abused? People aren't trying to abuse the system. How do we mitigate that as much as possible? So you need to think through that process. And unfortunately, we do have individuals within the EMS industry. You always have bottom feeders that make it unfortunate for a lot. But if we can advocate correctly for this and understand what the why of what this is about, we can try to change it and make it as retroactive as possible. While it may not be inclusive of everyone, it will be a benefit to at least making, because there was a lot of EMS agencies that didn't have a choice to do but to treat in lieu of transport. There was no choice involved as well. So step one is we've got to get the 1135 waiver. Step two is understanding what your community-wide EMS protocol is. I'm not going to opine too much on this because Brian just gave a very illustrative examples of this, what it's meant. This is actually the section within the actual statute of what it says, but such transport did not occur as a result of a community-wide EMS protocol due to the public health emergency.
That underlined language that's really triggering the debate here, because it can be viewed very narrowly to apply only to changes to an existing protocol, community-wide, that were made in response, direct response to the public health emergency. That's the narrowest possible view of this, right? Unless your existing protocols said, so to use that one as an example, if your existing protocol said that you can treat a diabetic crisis on scene and not transport them, then that wouldn't be eligible under that very narrow version, right? Because it wasn't a change to the protocol in response to the public health emergency. The wider view is that it's the result of a community-wide protocol, regardless of when that protocol was implemented, but the condition that triggers your ability not to respond, not to transport, is not based on the protocol changing due to the public health emergency, but the underlying circumstances. So for instance, a protocol that says you may treat them in place if the existing wall time at your hospital is more than 2 hours, right? But the reason, and that protocol has not changed as a result of the pandemic, but now the reason why the hospitals have 2+ hour wall times is responding to the public health emergency, then it would cover it, right? So there are multiple different interpretations of this language, and this is one of the reasons that it's so difficult. All this language does is give CMS the right to implement the waiver. It will be up to CMS to take as narrow or as expansive an interpretation of this authority as they believe is appropriate, right?
And I think too that given if we can make sure that they understand how do we what components do they need to consider to mitigate any unintended consequences or abuse to this type of protocol. And so I think if we keep that within context, there's different ways that you can look at it. There's written orders, there's non-written orders, or there's verbal orders that could come directly from a hospital. Is there a way to govern this through the process? I mean, there's a lot of discussion happening. Well, a lot of this stuff is recorded as well. So there could not be a written protocol or whatever, but there was a verbal order given over a recorded line that said, hey, our hospital cannot receive any patients unless they are priority 1 or acute emergency conditions or only COVID type patients. Other than that, we're asking you to treat in place or we don't have capacity at this point in time. There's different ways of nuancing and looking at that, but we got to make sure that we paint a clear picture with the end goal in mind.
Protocols have to be in writing. It could certainly be, I mean, in theory, it could be as expansive as the controlling medical director at a particular hospital getting on the radio and saying, attention, all EMS providers on this channel, right? Unless they're dying, leave them where they are, right? In theory, it could be as broad as that. So a lot of the questions that are probably circling about the exact implementation of this are to be determined based on how expansive or narrow CMS puts it out there. So all good questions, no doubt. The short answer is we don't know. No one knows until CMS acts.
And no one knows. And of course, I'm going to kind of talk through the realistic perspective. Remember how the TA came back. Remember the concerns of CMS and remember the score. And so if you think they're just going to expand this and make it for everything and their TA was concerned about abuse, and it was a $10 million score that CBO came back with because of that TA, then I have swampland in Kansas to sell you. And I'm just being very real about it, that it's probably not going to be as expansive as you think it is when you understand those concepts. And that's kind of why I wanted to predicate the beginning of this with that.
And that $10 million number, we should point out, is a net number, right? In theory, this should have a score of 0 because, again, if the only reason the transport didn't occur, right, is the protocol, then in theory, every claim that's paid under this new authority is swapping out, right, a transport that otherwise would have been paid anyway. So I think the big thing is not the number itself, but the fact that it's small.
It's
CMS
minuscule.
clearly does not,
Yeah.
sorry, CBS. CBO clearly does not believe that this is going to be potentially applicable to the vast majority of the emergent responses you do for Medicare patients.
Hence the reason why the
small fraction.
Hence the reason why it's the treatment in lieu, or people are calling tilt, which I really like Donna's talking about tilted way of looking at it. But let's just say all that happens. What do you need to make sure? What if it was retro? Billing documentation is still going to be whatever. They're not going to waive the rules related to your billing documentation and having adequate documentation or whatever. So step 3 is make sure you have that. If this waiver happens, you need to be doing your own inventory sheet on what does this look like? What does my billing documentation look like?
Yeah, and I think definitely take a look at the billing guide for the ET3 model for treatment in place there, because that's the closest thing we've gotten to what CMS expects to see in terms of documentation without a transport, right?
And the only thing that I would as we do a deep dive into it, folks, we talked about the different protocols. And I want to kind of leave it open as you guys have questions as well. It's really the HCPCS codes that you're going to be looking at is AO427, AO429 for the most part. I doubt you're going to be doing an AO433 or an ALS2 patient and treating them in place in lieu of transport. I highly doubt that's going to happen. It could, but I highly doubt it. You're not going to be billing for mileage. That's easy. If you're doing the ET3 model, the ET3 is asking for a modifier of W, this PHE waiver. Expect that they're probably going to give us some type of modifier from CMS if they do implement the waiver, how you would bill that as well. Of course, we will all advocate to make it as simple as possible as well, but just know that that would be left up to CMS to identify what that waiver or what that modifier will be, because a lot of you are like, well, how will we bill this? What will we do? Will it follow ET3? That we don't know. More than likely, it will not follow the ET3 model. And the reason why I say that is because the alternative destination did not follow the ET3 model. They had to change those nuances. So I would expect the same thing to happen. So if you're doing ET3, it's not going to follow that same. I would suggest that they're probably going to follow something similar.
But it blessedly gets rid of that telehealth piece.
Yeah. Oh, it does. That it does. And so the documentation side of it, guys, to just be very clear, a lot of you have called, asked questions, text, like what kind of documentation do you think would be? I'm an analogy person. So kind of think like your AMA documentation. I'm filling out a medical record. Of course, I'm not going to be doing the against medical advice disclosure on that treat in lieu of transport, but it's going to be medical documentation similar to how you do with an AMA. You're going to have to give them a HIPAA privacy notice like anything else. You're going to have signature pages in order to bill. Same concept, not much. I would strongly suggest a treatment in lieu of transport attestation statement or disclosure statement to them as well. I am suggesting you put that. I'm giving you one for illustrative purposes only. Get with your attorney. Several of you guys use Brian Werfel or PWW or some other legal counsel to work with you on an attestation. I'll let Brian opine on this. I'm just throwing something there for an illustrative purposes that I would strongly suggest that you have with a treatment in lieu of transport through this process as well. Brian?
Yeah, I mean, the lawyer in me, I understand the need for something like this. I just don't like it because in theory, the patient's consent is irrelevant, right? The reason why I'm not transporting them is not because I've talked the patient out of being transported, right? That's ET3. The reason why I'm not transporting them is because whether the patient wants to go or not, the protocol says I can't take them, right? So certainly I would want to tell the patient that or explain to them that, like it or not, you're staying here because society has made a broader public policy decision that your condition doesn't warrant hospital resources. Right. So you may need two different versions of this attestation statement, depending on the underlying reason for why you're not transporting them, because a protocol could be written to say you may not transport them, you shall not transport them, or it could say we're opening up the option for you not to transport this patient. And those two would be very different disclosures, right? Really what I think we want to make sure we have, though, is somewhere in that cruise documentation, we have to check the box that we can correlate back to that protocol, right? So if the protocol limits it to certain medical conditions, we need to make sure that one of those applicable medical conditions is there, right?
Correct.
Some of you may have condition codes that pop onto your EPCRs. That may be a way to do it. It's by no means the only way, right? So really what I would suggest is, I think the broader concept of some sort of disclosure to the patient is going to be needed, but I think the actual language is going to depend on the protocol itself, right? So again,
my suggestion, no, because I agree, because it really, Brian's the attorney, and while we tell you guys to look at legal counsel as well, Brian brings up a good point. A lot of you that are on here also use billing agencies to do your billing for them. And if it's specific to protocols, I'm strongly suggesting make sure your billing agencies know this, because they'll need to set up a different process of how they actually bill for this. So if it's certain protocols that are developed, all the other protocols are going to follow the normal billing procedure. These might do something differently as well. So it's going to be very important that operations is communicating, especially if you're using an external billing agency, through the process of how that would be done once the waiver is issued. Now, expect once the waiver is issued, we have a lot more regulations. We continue to do that piece through the process. Then expect us to do another webinar to kind of go into the nuances. But practically thinking, guys, I'm just saying, get ready for it. You're not going to see huge changes, them waiving medical necessity provisions. There's a few questions and lots of questions starting to come in. There's a question about, will the 12-month timely filing still apply? I will tell you this, that typically from the retroactivity of the waiver, if they put the waiver in and they make it retroactive, usually the time clock starts from there. You don't really need to worry too much about the timely filing limits if they retro it back to March the 1st. The waivers are going to help with that piece of it, so you don't really need to worry about timely filing. Somebody asked here, and keep your questions coming. Brian, you want to say anything about that?
Yeah, I would just say again, Asbel's generally correct that where they go retroactive, they're not going to arbitrarily impose their 1-year time limit. That time limit exists to ensure abuse. Their belief is that someone that sits on a valid claim for a long enough period of time, after a certain period of time, the likelihood that the claim itself is appropriate drops dramatically. Since they wouldn't be in a position to know it's billable until they implement the waiver, right? They'll likely make an exception for those claims. I think but again, no guarantees until we see what they do with the waiver. The next one that comes in from Donna, it's really 2 questions. So one piece of it is, would the treatment in place, or TILT as we're calling it here, allow for scheduled responses? That one's an easy one. No. The waiver authority granted to CMS is limited to 911 responses, or the equivalent in an area without 911. So what we in the industry would call emergency responses, right? So no, it wouldn't apply to scheduled transports. In terms of the A0427 versus A0429, so ALS emergency versus BLS emergency, the question is, would you be able to use the ALS assessment concept? So billing ALS, not because you provided an ALS intervention on scene, but because based on how it came in, it was reasonable to send a paramedic to assess the patient rather than, an EMT. Again, it's going to be up to CMS. My own personal belief is that since they've implemented the ALS assessment concept in the ET3 treatment in place intervention, I would see no reason why they wouldn't implement it here. And in fact, that is actually likely going to be the vast majority of these situations. And I don't say that in the sense of the vast majority of the responses, but the ALS assessment, for our purposes, is a situation where you're told a serious condition at dispatch, get on scene and it's less serious. And therefore, it was reasonable to send the medic, but not reasonable to provide an intervention, right? If it was reasonable to provide the intervention, I suspect many of the protocols that go into place are still going to require that they go to the hospital. So I think that ALS assessment, but where you get on scene and it's less serious, and therefore you can treat them and resolve the condition at the scene, is probably going to be the bulk of the ones that ultimately end up being billed under this, personally.
Technically, if they waive and CMS says they're not going to follow the normal regulatory authority for AO427, ALS assessment, ALS emergency. I doubt they're going to do that. They're probably just going to opine and say where it's medical necessity and reasonableness still stands. The fee schedule still stands. They're not going to waive that. Donna, that would answer your question. That ALS assessment would be considered in there if it follows the appropriate protocols.
I would
and
be
the billing requirements as well.
Don't include it as part of whatever waiver they issue.
There's a question here. Would you believe both medics should be signing all reports, including any treat in lieu of transport?
I'll give the legal answer. Asbel, you want to give the practical answer? Or,
yeah, go ahead. You give the legal, I'll give the practical.
Yeah, so this is a really common question. So it applies not just to the treatment of place, but just general documentation for Medicare. And the short answer is Medicare doesn't require both medics or both EMTs or both crew members to sign. Their authentication requirement is that the author of a medical record sign to certify to its accuracy. It's your state and local rules that indicate whether or not both crew members must sign or not. So if you're in a state that does require both, or a local jurisdiction that does require both, then both must sign. If they don't both sign, then you don't meet the Medicare requirement that you comply with all state and local requirements. If you're in a state that only requires the attending crew member to sign, then no, the second crew member isn't required to sign, but I would strongly recommend you do it, because what happens is, regardless of what the underlying requirement is in an appeal or an audit situation, frequently the auditors will incorrectly deny a claim because the other crew member didn't sign. And now off we go down the appeals road of arguing that you didn't need to have them do it, right? And then you will invariably at some point in that discussion hear someone from the contractor say federal law trumps state law. And if you're me, you will just start banging your head repeatedly on the desk, because while that's true, it's irrelevant in this case. The federal law doesn't require it, but you will practically work towards making your life easier, especially if you use an EPCR where both sign in at the beginning of the day anyway, to just get both to sign it.
So practically speaking, best practices, get both medics always, or EMTs always to sign it. If you do not, and you get caught into an audit and you have that issue, hire Brian Werfel.
Actually, I believe Steve Worth is on the phone.
Or Steve Worth, or PWW, or anybody else, get an attorney. But I would strongly suggest that your practice always be that they always sign.
Right, and for my own sanity, I would strongly prefer that I not be the one that gets that call. So.
All right, Brian, turn it over to you guys. Thanks. Keep your questions coming in. Questions at Solutions Group. Brian, I'll turn it over to you.
You got it. Listen, Brian, Asbel, thank you both so much for helping put this together today. I want to thank all of our guests for joining us. Quick announcement about another upcoming webinar we have scheduled for April the 22nd. That's going to be at 11 o'clock Central Time. It's 12 o'clock Eastern, and it's going to be about enhancing compliance through the RCM process using your data. And so excited to have that put together. Our special guest is going to be Angela Johnson, or Angie from IMSA, as well as Mr. Werfel Esquire is going to join us as well. So we're excited about that event. We will push out an announcement for it, so you can be sure and sign up for it as well. And then one last piece for you guys today, for any more information about Solutions Group, you've got a quick brochure you can download here for it. Any questions that we didn't get to cover today, please hit us at questions@solutionsgroup.com, and one of our team members will definitely circle back to you. So thank you all for joining us. It's been a pleasure, and we look forward to seeing you guys on the next webinar. Take care.
Bye, y'all.
Thank you, everyone.
Thank you.
Are you balance billing more and more patients due to high deductible insurance? Are you recouping less and writing off more? Commonly, providers sacrifice their reimbursements by releasing claims too early, before the patient's deductible has been satisfied. And collection percentages on balance billing has a low rate of return. It's time for something better, something easier, something smarter. Solutions Group provides a leading-edge approach for better managing patient deductibles. Our solution monitors your referrals with private insurance and notifies you when the patient deductible later becomes satisfied. Imagine never again being surprised by unmet deductibles when billing private insurance. Imagine never again guessing when to release your claims. Plus, with one click, you can access live reporting tracking the progress of maturing patient deductibles, and you can view your referral pipeline from any computer, anywhere. Our results import updated insurance information directly into your billing system and there's never upfront cost. If our solution doesn't bring home additional revenue from commercial carriers, then you won't pay us a dime for our work. At the end of the day, you'll realize more dollars from commercial carriers, plus provide a better service to your patients. Solutions Group, connecting care with reimbursement.